Good evening. So I'll just give you a few pointers which were very helpful in the clinic, at least in my practice. So ocular allergy is one of my passions, and I've been following it closely all the latest developments in the field. So I have no financial interest to disclose. So basically, the first question you have to ask when you see a patient with itching in your clinic is it truly ocular allergy? Itching is the hallmark of ocular allergy. You can't make a diagnosis of allergy without it. But not all forms of itching or types of itching is actually an allergic conjunctivitis or allergic eye disease. So basically, if the patient is saying yes, my eyes are itchy, so you have to ask them after rubbing your eyes, do you feel better or the itching is getting worse with the eye rubbing? So if there is an improvement, it is not most likely not ocular allergy. It can be either dry eye disease, meibomian gland disorder, or blepharitis. If the itching is getting worse after the patient rubs their eyes, it is most likely ocular allergy. The rationale is the rubbing is causing the histamine release, which is worsening the symptoms. And also in your OPD, you can just put one drop of any anti-allergic eye drop which is available to you. If the patient reports an improvement after installation of the eye drop, it is most likely ocular allergy. So also, where is it itchy? So if it's in the canthus, the middle canthus, so that's most likely a hallmark of ocular allergy. If the eyelids are itchy, the eyelids, the eyelashes, the margins, either it is blepharitis or it is demodex, it can be chronic blepharoconjunctivitis also. So consider these locations and the questions when you make your diagnosis of allergy. So this is most likely the stringy ropey discharge which you see in allergic conjunctivitis. You evert the upper lid, you see the papillae. And this, however, if you see this colorate appearance on the base of the eyelashes, this is most likely demodex blepharitis and not allergic conjunctivitis. So the differentials, as I've said, is one is dry eye disease, you have infectious conjunctivitis, are they a contact lens user? Can certain drugs can cause this as a reaction? Blepharitis or demodex, giant papillary conjunctivitis, which is not actually true ocular allergy. And also patients have a habit of removing the mucus from their eyes with the fingernail. So this is mucus fishing syndrome, also mimics ocular allergy. So keep on taking history. That's the second pearl. Where do they live? What do they do? Is it a dusty, polluted area, or their profession is exposing them to some allergic triggers? Whether it is acute, whether it is chronic, how does it improve, how does it worsen? Also ask systemic components like rhinitis, otitis media, sinusitis, nasal polyps, frequent attacks of upper or lower respiratory tract infections, whether they are asthmatic or they are having eczema on the skin. So these, all of them are mostly associated with some form of ocular allergy, and it sometimes the allergy is run in families as well. So you can ask the accompanying family member if they have allergy as well. So if they are constantly rubbing, they have a runny nose, that is the nasal salute, their throat or ears are itchy, and whether they are contact lens users, all of these will help you support your diagnosis of ocular allergy. Classify this because each allergic subtype has a different form of management. Two of them are potentially blinding, that is the AKC and the VKC form. So be very careful when you're dealing with these two forms of ocular allergy. The environment, as I said, avoid the triggers, cold compresses and cooled artificial tears. I can't suffice or emphasize enough that how beautifully they work and help in relieving at least the acute form of allergy. And we have something called as the dual action and the antihistaminics and the mast cell stabilizers. So they are currently the first line of therapy because they have a rapid onset of action. They have longer duration as well. They have minimal side effects. Just the key is that especially the patients with seasonal allergy, you have to educate your patient to start these drops at least 2 weeks before the season change occurs or when their symptoms generally occur in which month. So at least 2 weeks you give the patient so that these drops work much better because they stabilize the mast cells before the actual the trigger occurs. So once the allergy is set in, the drops may not be very effective. If it's very severe, you may need steroids along with this. So at least 7 to 14 days before the actual allergy season starts, you have to educate your patient to use this. We have these formulations available in the market. You may use a higher strength dual action drugs if the symptoms are very severe to begin with. Artificial tears, yes, they help because they dilute the antigenic load by just mechanical action. They prevent the antigen and the mast cell interaction. So they do work well, especially in the giant papillary conjunctivitis where they provide a relief from the mechanical rub-in. Ectoin is one molecule which has been derived from bacteria and found in some artificial tear formulations. It is very interesting and an upcoming area of research. It helps in creating a physical barrier between the ocular surface and the antigen exposure. So again, it prevents this interaction and degranulation of the histamine. So these are the older forms which you should avoid, especially NSAIDs and the SIRF, the only mast cell stabilizers. They take 2 weeks to act, but they are more prone for toxic corneal complications, and we have better drugs available. The eighth pearl is corticosteroids. They are your best friend. They are your worst enemy as well. So be very careful in using them. They have vision-threatening side effects. We are all aware and seen them firsthand. So you have high and low potency drugs. So you can choose, take your pick, depending on how severe the allergic reaction is at presentation. The ninth pearl is the use of immunomodulators. We have two available in the market, that is topical cyclosporin and topical tacrolimus. Please keep in mind tacrolimus is an off-label indication in ophthalmology. We have it in the ointment formulation, not in drops. They're basically calcineurin inhibitors, not usually the first line of treatment in allergic conjunctivitis, only for refractive atopic or vernal keratoconjunctivitis. Very useful because they help in sparing the steroid and avoiding the side effects. I generally prescribe them for 3 months at a time. You can use them in cycles. And I prescribe them, I tell the patient to apply a thin layer over the eyelids and not over the ocular surface because they are very irritant. Especially tacrolimus, it is more potent but more irritant as well. So you apply a thin layer, it works through the eyelid skin and helps in the resolution of the papillae. This has also been shown in a recently published paper from RP Center. And the last pearl is immunotherapy, which is not a very new modality. Currently, it is the second line of treatment in allergic conjunctivitis. It can be given either as a subcutaneous injection or a sublingual oral tablet. You need to tie up with a very good allergy specialist. You try and find one in your city or maybe a bit even far also. The therapy may take 3 years, but it slowly desensitizes the patient towards that particular antigen and helps reduce the drop burden, the medicine burden on the ocular surface. So I have been regularly following this with an allergy specialist in Kolkata. So I regularly refer patients to him, especially those with the systemic signs of rhinitis or eczema or asthma or urticaria. And the results are wonderful. The drop burden just goes down. The patient is more comfortable and it really works well. So, and the last one, the curve I wish to show you all is this is something called as the bridging effect, in which you start the steroids, especially in severe VKC or AKC, that is at week 0, that is at presentation. And at the same time, you can put them on topical cyclosporin or tacrolimus because they take some time to act. And as the time goes by, the peak of the cyclosporin or tacrolimus lies, and that time you can start tapering the steroids. So you're sparing the steroids, you're not exposing the patient to for a longer period. At the same time, the cyclosporin or the tacrolimus starts acting and the patient goes into long-term remission. Thank you so much.
Aditya, I have got two questions for you.
Yes, sir.
One, nowadays there's too much of talk about Demodex and this tea tree oil.
Yes, sir.
So what is your take about that? And one product is there from FDC by the name of UV Tube,
yes,
for VKC. So what is your opinion about this?
So the first one is, yes, Demodex is definitely a very well documented clinical entity. The photograph which I showed you with the collarettes, you can remove that with the epilation forceps and look under the microscope to visualize the mite. So tea tree oil, yes, you can definitely use it. It works well. The problem is the availability and diluting it so that it doesn't, disturb the ocular surface. So we have one company which makes a foaming shampoo kind of a solution which has tea tree oil integrated into it. They also have wipes. So you can just instruct the patient to, have maintain their lid hygiene twice a day with the foaming shampoo. And at presentation, you can remove as much as those mites by plucking out the eyelashes. Also, these things are present in the daily items that they use. That is clothing, hand towels, bed sheets, mattresses, pillow covers. So these mites are present in those objects. So you should also instruct them to just, put them out in the sun or dust the mattress or wash the items more frequently. They can also use soaps which contain tea tree oil. They are commercially available. So as part of their bathing routine, they can substitute the current soap which they use with something which contains tea tree oil. And the second one, sir, I don't have any experience with
UV from
UV lobe, that is chloroquine.
chloroquine.
Chloroquine is something that was available, is still available now,
available,
and I think it does work well. We just did one study where we compared chloroquine with cyclosporin, but that was in refractive surgery patients, and we found that both of them did well. It was a non-superiority study, so there was no superiority established over the other.
Okay.
For allergic eye disease, I think people have given in anecdotal cases, but there are no studies to
Now
show
the
whether it works
The
or not.
company says that for 3 to 6 months of for VKC, it works very well. Chloroquine.
Okay, Dr. Aditya, that is very nice. But I have one question from the practical point of view of practitioners. We see these allergic diseases in very, very young children,
Yes.
So do you recommend any particular molecule for a particular age group or deny a particular molecule for the younger age group, something like that?
No, sir, nothing like that. The three molecules which I showed you, you can take your pick. Most of them are US FDA approved for generally starting from 2 years and up. Before that, you generally don't see at that age, less than 2 years or 3 years of age, you generally don't see
Even the cyclosporins?
Cyclosporin you can use, not a problem.
Thank you, Aditya.
Thank
And
you.
we come to the last talk